Welcome back. I'm Dr. B, and my my client here is Nate Vandegraff. He's got a lot of anatomy and physiology history in his family. His uncle wrote a very famous textbook used across the country at the collegiate level in anatomy and physiology. And he's, as a professor, taught a number of places. One of my mentors. Of course, we're cleansing our hands because of COVID. We've spoke before. He's had it. I've had the first shot. We have no symptomology, and I need to see his countenance. Very important to me, even though Hoppenfield does not address it, but he's dealing with the various population, and I was used to be dealing with athletes who have paid a big price to be where they're at. They love the practice. They know they need to pay that price to get their starting position, and their words will say other than their countenance. So I quickly learned to watch the countenance. Having cleansed our hands, the purpose of this video is from Hoppenfield on the shoulder. We're going to do range of motion, which includes AROM, active range of motion. The client is doing it themselves. And PROM, I'm doing it to the client. And at the end of that, we will add a neuro examination. And that's what we will be accomplishing on this film. When we start, male or female with a sports bra, whatever, we're going to have them, please shed your shirt if you would. Of course, I'm looking for fluidity, symmetry, posture, proportion, color, contraction, condition, and creases. And it's real obvious to me again, in a previous film, he's dropped his right shoulder, left shoulder is higher. He is dropping his dominant arm, which is typical if you're going to drop an arm, but his power events are with his he's left hand, fine motor skills, right arm, gross motor skills. Very well. Good thing he's here to keep me on track. I'm going to watch as he sheds his shirt to look for the visual tests, fluidity, symmetry, posture, proportion, etc. Now, we're going to do what we call, let's talk about the shoulder. The shoulder girdle consists of the sternoclavicular joint, the strut of the clavicle, we got the acromioclavicular joint, the glenohumeral ball and socket, and the scapulothoracic, which we refer to as an articulation, because it moves, but it's not diarthrodial with the capsule and articulating cartilage. It was soft tissue on soft tissue. We're going to start with Apley's scratch test for active range of motion, and from there we'll go to passive range of motion. Now, Apley's scratch test, you'll find that I'm teaching basics here, and you'll go to a clinic and shadow somebody, and they'll tweak it a little bit, and that's just fine. But as far as this class is concerned, we will stick with Apley unless I modify it. And I'm going to modify it here a little bit today. Active range of motion, if you would please, let's do bilateral. We're going to do bilateral shoulder abduction. To the client, I would say, please clap your hands above your head. Like this. Go ahead. Notice that when he gets, and hold, when he gets to 90 degrees, he started with his hands, forearm pronated. When we get here, we naturally supinate and externally rotate. I'll expound upon that a little bit later, but basically the surgical neck of the humerus is impinged upon the acromion process. He can still clap the back of your hands together above your head, but it's a little bit difficult. Can you touch him? Usually, but we have to throw some elbow flexion in. When you supinate, turn your palms up, you can easily clap above your head. Again, because you've externally rotated. That is normal movement with active range of motion. So, bilateral shoulder abduction. Now, I'm going to have you, please, both arms behind your head. We're doing bilateral shoulder abduction. Lock your fingers behind your neck. And now, push your elbows back. Now we're doing bilateral shoulder abduction and external rotation to get into that position. Now bring your arms back down to neutral. And now we're going to have you cross in front and touch opposite shoulders. Active range of motion of bilateral adduction, A4-4, and shoulder bilateral internal rotation. From there, I'm going to have you, and hop and fill doesn't do this. Relax, thank you. Bring your palms shooting forward. Come toward me if you would. There you go. And just bring your arms up above your head, straight up. Like me. And of course, I'm watching his countenance, and if he's got any glitches, and I'm also checking out the lats here, etc. And bring him back down, bilateral shoulder flexion and extension. Other things are occurring at the elbow at times and the wrist, but we're not involved with that right now. In the sagittal plane around a medial lateral axis. Now we're going to do more. Please, with your elbows locked into your ribs, bring your arms with your elbow bent at 90 degrees, like me, across the front. Bilateral shoulder internal rotation and bilateral shoulder external rotation. In this course, I do not hold you responsible for the degrees of range of motion. You'll get that if you're going to pursue that career in graduate school or in the clinical setting. And relax, put your arms down to the side. So we've done all of the planes. And one last one is adduction A44 and extreme internal rotation. Please reach behind your back with both arms and reach up on your shoulder blade as far as you can.
Want me to turn around?
Not necessary to turn around because I'm just watching the shoulder here. Okay, and this has elbows involved and everything else. And if he did have a limitation, then I would start measuring from inferior angle to fingertips. His right arm, his dominant gross motor arm, does reach higher because he does the big ballistic workouts there, throwing the baseball, etc. And his left hand is about 5 or 6 inches below the inferior angle of the scapula. And relax. That is bilateral active range of motion Apley's scratch test. We did a few more than Hoppenfield actually gets into by referring to Apley's scratch. Now we're going to go unilateral. If you start to see a problem, we will go with one arm. Please reach up. We're going to do abduction A24 and external rotation. Please bring your hand up and touch behind your opposite shoulder blade. And of course, I'm looking for all the visual things, and not just the shoulder, I'm watching the countenance, and for any compensatory movement. The body will try to do something else if it's difficult to do that, and bring it back down. And of course, then you would do this bilaterally with the other limb, but we won't take the time to do that. That was abduction A24 and external rotation. Now please come across and touch the other shoulder. Like that. That is adduction A44 and internal rotation. Not a lot of internal rotation, but it's there. Thank you. And now, please touch the small of your back down around behind you. You're not necessarily reaching for your shoulder blade. We have adduction, reach across as far as you can, and again, internal rotation. And those also are Apley's unilateral scratch test. Now there's something I want to read from the textbook here that I don't usually do on film, but if we were face-to-face in the class, I would have students go ahead and read it because it is so well written and a few paragraphs summarize a few things so very well. Let me take a look here. Okay, if you would please, Nate, we are on page 22, below the bold passive range of motion test, halfway down. It talks about some things. First of all, I'll refer to it. If you do have tightness in the active range of motion, it's for one of 4 reasons, one of which is muscle weakness. You may also have contracture of muscle, an irregular, relatively permanent shortening of soft tissue. We might also have a contracture of soft tissue. That now will feel firm with a little bit of springy. And if that's what you experience, you're limited by firm yet springy limitation. He can't go all the way into abduction or flexion or whatever. Then that we consider extracapsular. it's soft tissue, and it's outside the synovial capsule. It's pathologic because it's limited in motion, even though it's still firm and springy like a normal capsular feel, but it's limiting motion. So that's contracture of a soft tissue, the third reason. A fourth reason is because of bony block, meaning bony obstruction in the joint, more than normal. You hyperextend the elbow, you lock out, that's a bony end feel. If you get that in the shoulder glenohumeral joint, that's not natural. We consider it intra-articular. It's inside the capsule, and we call it a bony block, is the limiting reason. So muscle atrophy, muscle contracture, soft tissue contracture, may be a bursa, may be ligamentous, may be capsular, and then finally we have bony block. Now, Nate, if you would please read, we're in the underneath passive range of motion test, page 22, halfway down.
Positive testing eliminates the patient's own muscle strength from consideration as a variable since the examiner supplies the power.
Continue, and we're going to go clear to here.
Okay.
But I might interrupt.
A passive test then is used to detect whether a limitation in range of motion is consistent both with and without muscle power. If the joint moves through a full range of motion under passive testing conditions, but has restricted active motion, you may assume that muscle weakness is the cause of restriction.
And hold. Or pain. So he cannot move. Bring your elbow up to here, please. Let's say that's as high as he can go when we should get 180 degrees. And relax. Now I will test that. Thank you. I'll test that, and he can go all the way up. The narrative here is saying that we can likely assume, not 100%, but likely, that it's weakness of the muscle and also add and/or pain. He may not want to go past here using the muscle. It's pain in the muscle. But Hoppenfield doesn't mention pain. So that's what that paragraph was saying right there. And we can turn right back to it in a hurry. And we're going to continue reading from that spot. We are right here, please.
If restriction is consistent under passive test conditions, muscle weakness can usually be eliminated.
So if it doesn't hurt when I do it to him, but it did hurt when he did it, then it's muscle. That's the variable, most likely.
Muscle weakness can usually be eliminated as the direct cause, and bony intra-articular or soft tissue extra-articular blockage is most likely. Although muscle weakness may also exist as a result of non-utilization of the joint.
Continue, please. Next paragraph.
To distinguish between intra-articular and extra-articular blockage, check the quality and feel of the blockage within the joint. If the blockage has a rubbery feel and gives slightly under pressure, there is probably an extra-articular soft tissue blockage. If, on the other hand, the blockage seems inflexible and range of motion ends abruptly, there is probably a intra-articular or bony blockage.
Last paragraph.
It must be emphasized that the patient should be totally relaxed during these tests, for if he is tense, afraid, or insecure in your hands, his muscles will tense and splint the joint, not allowing a full passive range of motion. It is essential, therefore, that these tests be administered gently. Passive testing can be conducted with the patient either standing or sitting. His elbow should be bent during the test because flexion of the elbow cuts down the sweep of the arm.
And that'll do. Thank you. Make sure you understand that, because this is monstrous huge with our musculoskeletal assessment that we're doing in this class. Having said that, we've done aptly, scratch, active range of motion, passive range of motion now. I want to, very similar to manual muscle tests, my passive range of motion I perform to the client becomes the same technique as manual muscle tests when we do neurologic strength assessment, except you start to add the resistance for the grade 4 and the grade 5. I want to eliminate compensatory movements. We're not going to check range of motion here or here. We're going to do the glenohumeral. Being a ball and socket joint, it has 9 movements, and we are triplanar and triaxial. We're going to stabilize so that we don't get other things taking place by bringing the elbow into the ribs. And remember, we talked previously about a firm but gentle grip that communicates confidence and comfort to the client. I'm going to have you relax, just flop. There you go. Make sure you've got the arm better than a previous film. Nicely done. Not always easy to do. I'm going to fix it here, and I'm now going to do all the work. Your job is to relax. Let me know if anything hurts. I've already touched you because prior to the video, I got permission to touch the muscles and skin and bones of your shoulder in order to assess your shoulder. If there's anything I do that makes you uncomfortable, you let me know. And I need to know if it hurts. Don't mask it, because that tells us if something's wrong that we're trying to find out so we can repair it. I'm simply going to do internal rotation of the glenohumeral. Internal rotation and external rotation. With manual muscle test, I could turn it right into that then and say, just relax your arm there, make a fist, but hold your arm here. Now, take my hand into your belly, please, and on the inside, we're going to hold, and relax, and take it back. Now I'm going to do the same thing going back. Turn your fist out, but notice I'm keeping the elbow into the ribs so we truly isolate the movement here. Internal rotation, external rotation, shoulder flexion, up to here and even higher. Shoulder extension back to neutral. Hyperextension is beyond neutral. And there he helped me. See how he's got it going there? Totally relaxed. I want to make sure I'm doing it. This client is educated and can anticipate what I'm doing when I speak to you who know sports medicine speak. So he just does what he hears me say.
I'll stop.
Okay, so we can do passive here. That's not easy if you are testing both together. I have to really quiz or remind the client to don't do anything you're not told. You tell them, I'm going to test your shoulder, they'll start taking their shirt off, but no, we don't want you to do anything that you're not told. And I encourage you to get together with the teammates so you can check and balance each other. So we did internal rotation, external rotation, flexion, extension, hyperextension. We can do abduction and turn it up, on in, and we can do adduction. And we can keep it small because a long lever puts more stress on the shoulder. We're going to shorten the mechanical lever and combine all 3 planes, actually it's just 2 planes, and do circumduction. I'm going to have you turn and face the screen, please. Since it is the shoulder girdle, we are also dealing with the articulation scapulothoracic. So please shrug your shoulders up and down. For manual muscle test, I could resist here. Please, when you do, I'm going to passively do upward rotation. The scapula, well, let's go there right now. The first 20 degrees of abduction, A24, is purely glenohumeral. After 20 degrees, the scapula starts to kick in, and it's a 2-to-1 ratio. I will hold you for these numbers. 20 degrees of pure abduction, A24. Then after 20 degrees, it's a 2-to-1 ratio. Every 2 degrees of glenohumeral abduction, A24, we're going to have 1 degree of scapular upward rotation. Your reference is either the acromion process, but better yet is the inferior angle of the scapula. Unless I'm super involved in neuro, I'm not going to be adding a goniometer to this. I'm just watching that this is taking place. And I'm not super concerned because he had it in the first place. Being able to go up, you get to about 120 degrees of abduction. Here's 90, here's 180, half of 90 is 45. Above that, 90, 125, 120 degrees, so halfway to the 180. Now the surgical neck is going to be obstructed by the acromion. So we need to, and remember, you're still doing passive. He's relaxed. Then this is still a 2 to 1, 2 degrees here, 1 degree here, taking him up into 90. If they cannot get past 20 degrees, go ahead and turn around. You have seen grandma who will comb her hair like this or reach for things like this. The problem there is they've got what we call frozen shoulder. We've got a contracture of the soft tissues in the girdle limiting the scapula. And if the scapula can't do upward rotation, you're stuck at 20 degrees glenohumeral. And then you're going to compensate with lateral side flexion in order to get the arm high enough to reach the medications in the window or to wash the window or to get the plate out of the drawer, the cabinet. So you'll know what that is. Frozen shoulder, it's a limitation of typically a soft tissue issue of the scapulothoracic articulation. We also have, go ahead and turn the screen again. So we've done all of our ranges of motion here, but we've got some more here. Let's go this way. I'm going to have you put your arm out straight, and now just push it further forward, okay? Scapula is moving around. This is protraction, and then bring it back and squeeze your shoulder blades together, retraction. For manual muscle on test on that, you'd resist him protracting, push forward, stabilize here, push forward, and then I'm going to try to make or break. And this is tough, but retraction, you can hold it here. Hoppenfield actually has you tie up the vertebral border, bring your shoulder blades back together. We'll talk in special tests on the next film in sequence about winged scapula. Purpose of the serratus anterior is to tie the vertebral border anterior aspect over to the rib cage. So we have these muscles here in the axillary zone 3 of soft tissue palpation. And when you're doing protraction, retraction, or stabilizing, if that serratus anterior is weak, the scapula will wing out like this. You've seen youngsters, I watched one in the store yesterday, with his t-shirt, his scapula were sticking clear out like this, instantly knew he's got a weak serratus anterior. Winged scapula is what that condition is called. That is all of the active and passive range of motion for the shoulder. Now we're going to tie neurologic into it. Let's start with dermatomes. Not too much going on with dermatomes. In the shoulder, all I'm going to hold you for is C5. And up in the upper traps, C3 and 4. So 3, 4, 5. 6 is the lateral forearm. 8 is there, 7 is there. T1 is in the elbow. T2 is up in the axillary region for dermatome. For reflex, we don't have any in the shoulder. The first one is the biceps brachii C5. So in the shoulder girdle, we're not dealing with reflex. Now, get your paper and pencil out. This is not in Hoppenfield. This is a note in your margins. Hoppenfield will designate like truly 2 or 3 nerve roots for a gross motor movement. And I'm only going to hold you for one branch. In this course, we don't recreate and sketch the brachioplexus, so we're going to simplify to one level. And we're going to start with C3, well, cranial 11, and go clear up through C8. Motor. We did learn originally earlier in the class, so abduction is A24 is C5. I'm going to have you face the screen, please. Now, manual muscle test. You would provide resistance. Cranial nerve 11, go ahead and relax here. Cranial nerve 11 and C3-4 is scapular elevation. Please shrug your shoulders up and hold them there. Don't let me take them down. And relax. Cranial 11, spinal accessory, viewed some hawks or hops, and then C3-4. C5 is scapular protraction. Please put your arm up here, arm out straight, and now without moving your trunk, just push the arm forward. Go and hold it there, don't let me take it back, stabilizing the scapular shoulder girdle. There's 5. That's protraction. Retraction, pinching your shoulder blades, please. Go ahead and bring your shoulder blades back, is 6, C6, okay? So we have cranial 11, C3-4, C5, C6, and now we're back to C5. Facing the camera. Please bring this arm, elbow out to your side right here. Touch my hand, okay? This is C5, shoulder abduction. Relax. And I would test it. I'm not going to demonstrate MMT. You understand MMT. Hoppenfield will explain it, but you can work it through with the common variables. I'm just showing you C5. So, abduction, C5. Bring your arm up to here, please, and down. C5-6 is shoulder flexion. Please do this with your elbow bent. There you go. C5-6. Bring it back down. Shoulder extension is C5, 5-6, 6 is external rotation. Turn the arm out is external rotation. Internal rotation, 6-7. 7 is shoulder extension, just going back. And 8 is adduction, A4-4. It's a video, you can review it, but we're going to do it again. Face that way, and I'm going to do it facing forward. Cranial 11 and C3-4, shoulder shrug, shoulder elevation. Okay, C5 is shoulder protraction, arms jetted out front. Okay, C6 is shoulder retraction. Back to C5, shoulder abduction to the side. C5 is to the side. 6-7 is shoulder flexion. C5-6. Be aware, I've done 5, a whole number, and then 2 numbers. Then a whole number, and then 2 numbers. A whole number, and then 2 numbers. So, 5 is abduction, A2-4. 5-6 is flexion. 6 is external rotation. 6-7 is internal rotation. 7 is extension. And adduction, A4-4, is C8. And that's the neuro. No reflex. C3, 4, 5, T2 for dermatome, and motor we just represented. Those are the exams, and make note of those nerve roots. Go ahead and turn around. And this is our recording for shoulder active and passive range of motion and neurologic test. Thank you.